to all. This is an educational video in partial completion of the course Complex Nursing Situations at the University of the Bahamas. This is Group 7 and our topic is intubation and ventilation. Our group members are Zaria Thompson, Tamika Mingo, Vantasia Roll, Shakira Strawn, and myself, Nadicia Wiley. Zaria will now come with what is intubation.
Intubation is the process of inserting an endotracheal tube through the mouth and then into the trachea. This is done so that the patient can be placed on a ventilator to assist with breathing during anesthesia, sedation, or severe illness. The tube is connected to a ventilator, which pushes air into the lungs to deliver a breath to the patient.
What is ventilation? Ventilation is the process by which air moves freely into and out of the lungs due to the difference between intrapulmonary pressure inside the lungs and atmospheric pressure. With the command of the central nervous system, the brain, the spinal cord, the muscles of ventilation contract, the thorax and lungs expand, and the intrapulmonary pressure falls. As the pressure falls below the atmospheric pressure, air enters the lungs and inhalation occurs. When inhalation is complete, the muscles of ventilation relax while the thorax contracts and the lungs are compressed. And intrapulmonary pressure rises. As the pressure rises above the atmospheric pressure, air exits the lungs and exhalation occurs. And this is the process with which we are all doing now, which is breathing. And it is the process by which air flows into the lungs during inspiration or inhalation and out of the lungs during expiration or exhalation.
Now we are going to discuss indications for intubation. The main indication for intubation is respiratory distress. Other indications include if the patient is displaying hypoxia or hypoventilation to minimize oxygen consumption and maximize oxygen delivery, or if the patient has a head or neck injury resulting in airway obstruction. Also, if there is a need to protect neurologic function.
Let's say the airway becomes narrowed or blocked as a result of a disease, bronchoconstriction, a foreign body, or secretions, or let's say the patient has respiratory failure. This results from inadequate gas exchange by the respiratory system of the atrial oxygen, carbon dioxide, or both cannot be kept at normal levels. The respiratory system fails to do its main function, which is gas exchange, in which the partial pressure of oxygen is lower than 60 and or the partial pressure of carbon dioxide higher than 50. When this acidotic state happens, a patient will have to be mechanically ventilated, which is the use of a machine that is called a ventilator or a respirator to improve the exchange of air between the lungs and the atmosphere. Mechanical ventilation is indicated when the patient's spontaneous ventilation is inadequate to sustain life due to physiologic and clinical reasons. Physiological objectives include supporting cardiopulmonary gas exchange, increasing lung volume, and reducing the work of breathing. Clinical objectives include reversing hypercapnic or hypoxemic respiratory failure due to airway chest wall or respiratory muscle disease, such as pulmonary edema, pneumonia, and pulmonary hemorrhage. Reversing acute respiratory acidosis, relieving respiratory distress, preventing atelectasis and respiratory muscle fatigue, permitting sedation and neuromuscular blockade. As it relates to the contraindications of mechanical ventilation, there are no absolute contraindications because the need for mechanical ventilation is best made as early as clinical decision making. Waiting for laboratory values can result in unnecessary morbidity or mortality. The only absolute contradiction is when mechanical ventilation goes against the patient's stated wishes for artificial life-sustaining measures. The complications occurs when there is a prolonged use of the mechanical ventilations, can cause pneumothorax, airway injury, alveolar damage, ventilator-assisted pneumonia, and ventilator-assisted tracheobronchitis.
Types of intubation tubes. Endotracheal intubation is the passage of a tube through the nose or mouth into the trachea for maintenance of an airway during anesthesia or for maintenance of an impaired airway. Nasogastric intubation is the insertion of an endotracheal tube through the nose and into the stomach to relieve excess air from the stomach or to instill nutrients or medications. Nasotracheal intubation is the insertion of an endotracheal tube through the nose and into the trachea. This tube is passed without using the laryngoscope to view the glottic opening. Orotracheal intubation is the insertion of an endotracheal tube through the mouth and into the trachea. This type is performed much more frequently than the nasotracheal intubation. Tracheostomy intubation is placing a tube by incising the skin over the trachea and making a surgical wound in order to create an airway. Speaking tracheostomy tubes are specifically designed tracheostomy tubes that allow the ventilator-dependent client to speak by enabling air to enter the larynx without compromising the patient's or client's ventilation.
Ventilation modes are classified into two categories, that is, pressure and volume controlled modes. These modes are also described based on their trigger, their limit, and their cycle. The most common ventilation modes are ACV, assist control, SIMV, synchronized intermittent mandatory ventilation, and pressure support, PSV. The volume ventilation modes consist of ACV and SIMV. ACV, assist control ventilation, is also called continuous mandatory ventilation, and in this mode, the larger the volume, the more expiratory time is required. So each breath has the same volume, but is either an assist or a controlled breath. This mode is also not desirable for patients who have tachypnea because of the possibility of inducing hyperinflation and respiratory alkalosis. SIMV, in this mode, only a certain number of breaths is guaranteed, and they are partially the patient's own. They also reduce the risk of hyperinflation or alkalosis. However, increased work of breathing and a tendency to reduce cardiac output can prolong the patient's dependency on the ventilator. Patients who have ventricular dysfunction may have a decrease in cardiac output while on this mode. Pressure modes consist of PCV, that is pressure controlled ventilation. In this mode, no patient initiated breaths are allowed, and it has less risk of barotrauma as compared to the volume modes. Peak pressures are reduced in this mode and gas exchange is improved due to the decrease in the inspiratory flow pattern. However, there are no guarantees for the volume, but this mode is usually preferred for patients with neuromuscular disease. Pressure support ventilation also allows the regulation of inflation volume and respiratory frequency, and is only used to supplement spontaneous breathing because it is pressure controlled. There are other types of pressure ventilation modes, and they consist of pressure controlled ventilation, PCV, pressure controlled inverse ratio ventilation, and airway pressure release ventilation. There are many abbreviated settings on the mechanical ventilator. The tidal volume, VT, is the volume of gas delivered to the patient by the ventilator, and it is programmed by the weight of the patient. A high tidal volume can also cause hyperventilation and respiratory alkalosis due to excess pressure in the lungs. The respiratory rate, RR, or F for frequency, is the number of breaths given to the patient by the ventilator, and it ranges between 10 to 12 breaths per minute. FiO2 is the fraction of inspired oxygen, the percentage of oxygen given to the patient adjusted to maintain normal ABGs and oxygen saturation, and this ranges from 21 to 100%. PEEP, positive end expiratory pressure, is the amount of air that is left in the lungs after exhalation, and it is maintained by the ventilator. IE, inspiratory expiratory ratio, has a longer expiratory phase than inspiratory, and that is 1 to 2 or 1 to 3. The inverse ratio has a longer inspiratory phase, that is 1 to 1, 2 to 1, 3 to 1, or 4 to 1. PIP, peak inspiratory pressure, is the highest proximal airway pressure obtained during inspiration. The targeted PIP is less than 35 centimeters of H2O. High numbers can cause lung damage, while low numbers can cause hypoventilation.
Now we are going to discuss the case study. A 57-year-old male resident of New Providence was admitted to the accident emergency department via emergency medical services with a history of falling between the bed and the dresser after having 1 or 2 drinks. He has a past medical history of hypertension, diabetes, and right-sided cerebrovascular accident in 2013. He is maintained on Janumet 50,000 milligrams, aspirin 81 milligrams, Predirex 2.5 over 0.625 milligrams, amlodipine 5 milligrams, glycolizide 30 milligrams. He's noted to be compliant on all of these medications. While in A&E, he had multiple episodes of coffee ground emesis and was noted to have acute confusion. He was subsequently admitted to ICU on the 28th of December 2019. Upon admission to ICU, he was intubated and ventilated, receiving 80% oxygen. Further diagnostic procedures revealed he had a right middle cerebral artery infarct. He was scheduled for craniectomy immediately. Additional testing revealed he had infiltrates in the right lower lobes and an enlarged cardiac silhouette. Some drugs that he was maintained on while in the hospital included levofloxacin, 750 milligrams once a day. Levofloxacin is an antibiotic used in the treatment of pneumonia. Adverse reactions to levofloxacin include hypoglycemia and peripheral neuropathy. The patient should be monitored closely for these reactions. He was also receiving Zosyn, 4.5 milligrams every 6 hours. Zosyn is an extended spectrum penicillin antibiotic. It is indicated for use in patients with pneumonia and strains of bacteria that produce beta-lactamase. Adverse reactions to Zosyn include arrhythmias and dyspnea. He was also receiving labetalol, 20 milligrams IV for a systolic blood pressure greater than 160 and a diastolic blood pressure greater than 110. Labetalol is an alpha-beta blocker and antihypertensive used for hypertensive emergencies or severe hypertension. The patient should be monitored for adverse reactions such as bronchospasms or ventricular arrhythmias during labetalol administration. He was also receiving midazolam 5 milligrams IV. Midazolam is a Schedule 4 controlled substance. It's a benzodiazepine anxiolytic drug. It's commonly used as a continuous infusion to induce sedation during critical care patients. The patients on midazolam should be monitored for apnea, variations in blood pressure and pulse, or oversedation. Some laboratory studies from the patient are as follows. Upon admission, the patient's white blood cell count was 12.3. This indicates present infection or inflammation. His hemoglobin level was 9.3, which indicates possible anemia or excessive fluid intake. His hematocrit was 30.2. This indicates anemia. His platelets was 33.3, which was 30. His platelets was 334, which is normal. His blood urea nitrogen was 13 milligrams per day, which is normal, and his creatinine level was 0.7, which is also normal. On the 22nd of January, his white blood cell count was 12.1. This is decreased from the previous value on admission. This indicates present infection or inflammation that is worsening. His hemoglobin level was 9.7. This is decreased and indicating possible anemia, but it's increasing from the previous value. His hematocrit was 30.3%, and this is also increasing from the previous value, but it's still too low. His platelets was 322, which is decreasing from the previous value, but it's normal. His blood urea nitrogen was 11 milligrams per day. This is normal, but it's still decreasing from the previous value, which means this could indicate future renal impairment. His creatinine is 0.7, which also is normal. On the 28th of January 2020, his white blood cell count was 10.4. This is still deep. This is now normal, and it's decreased from the previous value, which indicates the antibiotic therapy that he is receiving is working. His hemoglobin level was 8.7. This is decreased, and it indicates worsening anemia. His blood urea nitrogen was 9 milligrams, and it's decreased from the previous value, indicating this patient is now having some renal impairment. His creatinine has also decreased to 0.6, further indicating that he is having renal impairments. His arterial blood gas results are as follows. His pH was 7.489. His PCO2 was 32.2. His bicarbonate was 23.9. Due to these arterial blood gas results, the patient was intubated to reduce the amount of carbon dioxide in the blood, circulating in the blood, and support cellular oxygenation.
The medical management of a patient who is mechanically ventilated. The goal of the therapy is to restore lung function, and careful medical monitoring of these patients can help reduce the time on the ventilator. Our patient had a middle cerebral artery infarct, which is the largest cerebral artery, and it is the vessel most commonly affected by cerebrovascular accident. The purpose of the mechanical ventilation is due to swallowing dysfunction and respiratory system compromise. As it relates to a patient being on a ventilator, one of the most common medical procedures is an atrial blood gas, which should be performed routinely to determine the heart's, lungs, and kidney function. Our patient ABG results were the pH was 7.3, partial carbon dioxide pressure 32.2, bicarbonate 23.9. The results show uncompensated respiratory alkalosis, which is due to hyperventilation and shows signs of hypoxemic, which the central sources are head injury and stroke. The most common used monitoring device is the pulse oximetry, which you will see that is attached to every patient. Is used for titrating fractional inspired oxygen concentration in patients on mechanical ventilators. As for the medical management, it is an early predictor of hypoxemia. Pulse oximetry can alert the medical staff immediately to know the need to provide treatment that can prevent further complications. Another medical management is alarm management. The ventilator settings alert clinical staff of a developing medical issue. The devices measure cardiovascular condition, pulmonary artery status, jugular saturation, intracranial pressure, and so many more other functions. The goal is to have a list of all percentages and pressure monitoring information. The ventilator settings and modes for our patient is checked routinely as for every and any patient to ensure that it is correct airway pressure and modes for the patient. And how would one know if the ventilator settings are appropriate for the patient? It would be clearly shown by the patient ABG values. The GCS is also frequently monitored to ensure the patient neurological status is not declining or that the treatment given is improving the patient's status. As for our patient, he had a history of falling and hitting his head with acute confusion. So the GCS is a clear indicator to know if the patient had traumatic brain injury. On the 28th of December, the patient GCS was a 13 while in A&E. On the 1st, there was a decline from a 10 because he had loss of consciousness and became unresponsive. So the patient was intubated and ventilated, and the GCS declined to a 6. While in ICU, a CT scan showed bilateral cerebral edema, so he had to have a decompressed craniotomy done. IV medications, such as for sedation, is also given for a patient who is on a ventilator, such as our patient was on midazolam, 5 milligram PRN if agitated. Also, if a patient is agitated, there are a high chance that they would self-extubate. So medical immobilization will be our order written, but our patient order was to be sedated if agitated. Another medication, as it correlates with the clear ventilation of the airway, is mucomist. Our patient received 3 cc's with 1 cc of normal saline every 8 hours. Along with the management of a patient on a ventilator, precautions are taken, such as every patient has to have a bag valve and mask located on the wall in the event if a patient self-extubates, when the patient isn't getting effective ventilation and oxygenation, or when the endotracheal tube is dislodged, a bag valve mask is required to oxygenate the patient manually until he or she is re-intubated. Also, suctioning is very important as it relates to the medical management of a patient on a ventilator, because as we know, it clears the secretions of the upper airway. Our patient was ordered to be suctioned every 1 to 2 hours, or if necessary. Once the problem that resulted on the need of a ventilatory support has been resolved, the patient should be considered for reduction of support. There is no set time for a patient to be on a ventilator, but as soon as the patient can breathe on their own, they are taken off of the mechanical ventilator. When assessment indicates partial support or discontinuation to be appropriate due to the stable vital signs and atrial blood gas within normal range, the medical staff change to a weaning protocol to extubate.
Nursing management of an intubated patient focuses on the effects of the respiratory system and other body systems that may be compromised, and it aims to optimize delivery. So some common nursing diagnoses for an intubated patient would be ineffective breathing pattern related to spinal cord injury, and this could be evidenced by abnormal breathing, nasal flaring, and tachypnea. Impaired gas exchange related to ventilation perfusion imbalance, as evidenced by hypoxemia, tachycardia, abnormal breathing pattern, and decrease in CO2 levels. Another nursing diagnosis that can be used is impaired spontaneous ventilation, and this can be related to impaired respiratory muscle failure, as evidenced by a decrease in arterial oxygen saturation, dyspnea, and tachycardia. All of these nursing diagnoses have interventions that the nurse must follow to prevent the complications of intubation and support optimization of oxygen delivery. So the nursing management for an endotracheal or tracheostomy tube focuses on tube placement and the effects of the respiratory and other body system. So the nursing intervention for intubated patients would include providing humidification of oxygen. You have to monitor the tube patient, suction the patient as necessary, establish a method of communication, and provide oral hygiene as needed. Additionally, the nurse must promote patient safety by monitoring tube placement for extubation, cuff injuries and an obstruction of tube and prevention of infection by maintaining an aseptic technique. So other nursing interventions for intubated patient addresses nursing diagnosis that can be specific to certain organ systems. So the nurse would assess the patient for cyanosis of the skin, which can be an indication of inadequate oxygen supply to the body. The nurse must also assess the ABGs and monitor them because increasing PaCO2 and a decreasing PaO2 can indicate respiratory failure. The nurse will prepare for and assist in the intubation process. The nurse should ensure inadequate fluid intake because maintaining hydration can reduce the causality of secretion. Additionally, the nurse can refer the patient for chest physiotherapy or CPT, for this allows for loosening of and mobilization of secretion. The nursing management for a ventilated patient focuses on routinely monitoring the patient for any patient-related or ventilator-related complications. Assessment of the patient on mechanical ventilation focuses on the pulmonary system, the placement of the ET tube or tracheostomy tube, and monitoring for the development of subcutaneous emphysema and dyspnea with the ventilation. However, depending on the severity of the patient condition, the nurse must conduct a bedside evaluation of critical capacity, minute ABG values, and other pulmonary function tests which may be necessary. The use of pulse oximetry can be used for continuous invasive assessment of oxygenation, and capnography can be used for continuous invasive assessment of ventilation. Static and dynamic compliance are also monitored to assess changes in lung compliance. Patients requiring mechanical ventilation can prevent a variety of symptoms include anxiety, shortness of breath, confusion, agitation, and sleep disturbances. These symptoms are often managed with sedation and analgesics. However, these medications can contribute to prolonged mechanical ventilation and delirium. Non-pharmacological interventions have been shown to be of benefit for patients who are mechanically ventilated. Some of these interventions include: you can promote a healing environment. The nurse must also promote sleep and promote interventions to lessen anxiety, which can be music therapy, guided imagery, nursing presence, and animal-assisted therapy. Nursing activities to promote a healing environment can include a reduction in noise levels, ensuring that the patient has access to natural light, establishing a method of communication with the patient, and explaining to the patient what is occurring around them. This can aid in rest for the patient and also relieve the sense of anxiety. Additionally, referring the patient to complementary and alternative therapy specialists is also appropriate. In managing a mechanically ventilated patient, the nurse must also consider using the awakening and breathing coordination delirium, monitoring early mobility, and family engagement and empowerment, also known as the ABCEF bundle. This bundle focuses on enhancing communication between team members on the critical
Caring for a patient who's intubated and ventilated requires teamwork, knowledge of care, and interventions based on best practices, the patient's needs, and the patient's response to therapy. So, nurses must be knowledgeable and confident when caring for ventilated patients. They also need to educate the patient and family to ease distress. So they would educate them on the importance of mechanical ventilation and intubation and emphasize the positive outcomes that it can provide. They also want to educate the patient on the importance of frequent assessment of vital signs, auscultation of breath sounds, ventilation checks, and this is to reduce anxiety within the patient. Also, educating the patient on the reason for them not being able to speak while intubated and explaining other alternative methods for them to communicate. And this is to reduce trauma to the vocal cords if they try to speak while intubated. Also, educating the client on the purpose of not being able to eat or drink while they are intubated, but assuring them that other alternative measures are being taken to provide nourishment. And you want to educate them on this because to avoid aspiration if the client eats or drinks while they are intubated. Educating or explaining that alarms may sound off and it may be normal and that the staff will always be in close proximity, and this is to help reduce anxiety when they hear certain sounds that they're not knowledgeable of. Also, educating the patient and the family on the weaning process and explaining that extubation demonstrates adequate respiratory function. And lastly, you want to educate or explain to the patient the need for suctioning as needed. This is to help reduce anxiety when you're suctioning the patient.
Now we are going to discuss critical thinking questions. Question 1 asks, what if my patient codes during the intubation process? If a patient codes or goes into cardiac arrest during intubation, then intubation should proceed. This is to support cellular oxygen supply and demand. Chest compressions during CPR should only be paused for 5 to 10 seconds to allow for the tube to pass. If chest compressions are paused for longer than this period, it can cause fatalities due to the already poor cellular oxygenation.
Critical question number 2. What if my patient bites their ET tube? A patient biting the endotracheal tube can be a cause of obstruction, which affects the volume and pressure delivered by the ventilator. Bite-related ET tube obstruction is a frequent cause of ventilator alarm activation and can cause respiratory failure, negative pressure pulmonary edema, and ET tube or pilot tube damage. Bite block or bite guards are highly recommended to be inserted into the mouths of the patients to prevent the tubes from being bitten or damaged, as well as to prevent the patient from biting their tongue, cheeks, or lips.
Studies have found that lower cuff pressures can currently provide an effective steal when the PEEP was less than 5 centimeters H2O, with a cuff threshold pressure of 12 centimeters H2O for sealing. Other studies have suggested that moisture or humidification also improves cuff sealing by partially filling folds and cuff channels.